All right, it's my distinct privilege to introduce Dr. Bruce Wilkoff. So I just wanted to thank him for coming all the way from Cleveland Clinic. It's a privilege to have people back in person again, and we've been trying that experiment for the past 6 months or a year or so, and it's been going pretty well. So it's been really good not to have last minute cancellations and other things, but we really thank you for coming. He's the director of cardiac pacing and tachyarrhythmia devices and a staff cardiologist at Cleveland Clinic. He's professor of medicine. And in terms of other things, Dr. Wilkoff is really world-renowned and internationally renowned. He's an expert in the design of new technologies to improve the performance of pacemakers and defibrillators. He's really a pioneer in lead management and lead extractions. And I've heard that he has a very personal story involving that issue as well. He's involved in numerous multi-center clinical trials, holds 9 US patents, including a special algorithm for defibrillator tachycardia detection and an efficient controller for pacemaker rate responsiveness. He served as the past president of the Heart Rhythm Society. I think you'll be going to HRS pretty soon in New Orleans again. But in terms of his background, he has a Bachelor of Science in Biomedical Engineering from Northwestern University. He got his medical degree from Ohio State and then did his clinical training in internal medicine at Case Western. After that, he completed fellowship at the University Hospitals of Cleveland. I believe that's Case Western as well. Fellowship research at Ohio State, and was appointed to Cleveland Clinic in 1986. So that's probably before some of you were born. And then in 2004, he became a professor of medicine at Cleveland Clinic. So it is our distinct privilege to have him here. A lot of the EPs in the group are in the room and others are in the lab right now and trying to watch you remotely. So we have a lot of people watching while doing cases. So thank you so much for coming, Bruce, and we look forward to your talk.
Thank you, everyone. And it's always fun to come back to Denver. I've been coming to Denver for many years for all sorts of reasons. You'll notice on the slides, I have a QR code, and I have this little logo here. It says Lead Connection, and it says leadconnection.org. One of my passions is optimal lead management. This is an online community that I've set up for collecting all information relative to lead management, from publications to press releases to education to discussions to podcasts to everything that there could be, and training opportunities. And I hope you will be part of this, this engaging every voice so that we can improve this. There's no other location, not from any manufacturer or anything, that that provides connection about all of these things. And we actively seek not only the participation of the clinicians, but all this information in one place so that we can improve care. These are my relationships with industry, with the device manufacturers and the extraction manufacturers, mostly. So I'm going to give you an update on RAPID. So first I'm going to explain what RAPID was. RAPID is the largest implantable device-related trial, randomized clinical trial. It was a worldwide clinical trial, and it produced some data on about 7,000 patients worldwide, 5 continents. But there was a lot of data that came from that. So there are well over a dozen manuscripts that came out of the trial. But I'm going to focus on 4 of the sub-manuscripts from the clinical trial. And essentially, the trial was a randomization of patients mostly with replacement or upgrade procedures for defibrillators, pacemakers, CRT, that they either got an absorbable antibiotic envelope or did not. And we looked at the infection rates. The primary endpoint was 1 year evidence of infection rates. We also did mortality. So this was the original paper, the main paper, antibacterial envelope to prevent infections of cardiac implantable devices, the New England Journal. And this was coordinated. This is a Medtronic product, but it was coordinated by Khaldun Tarachi, who was one of my partners at the time, and myself out of the Cleveland Clinic. So, but subsequent to that, there are 4 manuscripts that I want to make some points about that I think relate to well beyond just the surgical intervention. One is on microbiology of CIED infections. What are risk factors for those infections? Infection and the relationship to hematomas and the risk factors for hematomas. And we're going to talk about that and because I think they have some instructions for us. And these were all publications from 21 and 22. So first of all, the microbiology of pocket infections. So this was a local intervention where you put an envelope that absorbed within 3 months, but the antibiotics were there for about 10 days. But then we looked at the infection that came out of this. And the infections, and you see them splayed out in gray for control group, and in orange, those who had an envelope, Staphylococcus, other gram positives, gram negatives, and fungi. And you see that the major impact was both on the staphylococcal infections and the gram negatives. And actually, the rest of the infections were actually infrequent. This was first authored by Riz Sohail, who had been at Mayo's, now down at Tulane. It reduced, the control rate of infection was 1.3 at 12 months. At 36 months, it was 1.9%. And the envelope reduced overall infections 61%, but a 76% reduction of Staph aureus infections. Now, of the systemic infections, because we didn't take note of just the pocket infections, but the systemic infections, we see that the envelope really didn't have an impact on systemic infections, suggesting that maybe these infections were from a different mechanism, maybe not contamination at the time of surgery, maybe from metastatic infections from other things. And in this group, there was only 1 hematoma out of that group. So here's another bit of an insight. So when do these patients present? If I had asked people not too long ago when infections occur, they would have said quite early. And so we have our median times and the range for any pathogen, Staph aureus, coag-negative staph, and other bacteria for pocket infections and systemic infections. And I want you to see this, that the pocket infections, the median time was 174 days, plus or minus 234 days, meaning that almost 6 months was the average time that people presented with pocket infections. So the perception, common perception, is that pocket infections occur much earlier than that. And with a very long splay of 234 days for pocket infections, systemic infections actually occur almost twice as far out, 258 plus or minus 262. But if you look at Staph aureus, you will see that what's considered a very aggressive bacteria, some of these Staphylococcal aureus infections didn't occur until after 2 years after the pocket infection occurred, over 2 years afterwards. So an aggressive bacteria, but an indolent infection in many of these patients. So we also looked at risk factors for CIED infections, and you see these orange dots were increasing infection rates, and the blue dots, or I think they're blue, are decreased infection rates. The length of the procedure time, so the more complex the procedure, increase in the number of previous procedures, how many there were, history of atrial arrhythmias, which goes along with anticoagulant use other than warfarin or apixaban, the antiplatelets, whether you did capsulectomies, and whether you use cephalosporin versus vancomycin. And you can see the various, the more complex procedures, CRTD versus pacemakers or ICDs. And then the things that that reduced it, if you were not malnourished, if you did better. Fatter people did well. Again, anticoagulant using apixaban was a positive thing. Chlorhexidine PrEP and using an antibiotic wash, which it worked with. There were 17 risk factors, 6 patient risk factors, 11 procedure risk factors, 13 increased risk, and 4 reduced the risk. Now, one of the really important findings in these trials was the importance of hematomas. So of the people that had infections, 13% infection rate in patients who had hematomas, and only 2% risk in people who did not have hematomas. And then if you used the envelope, it brought the infection rate way down, both in hematomas and non-hematoma patients. But the point is that hematomas were a very strong predictor of having an infection. And in fact, these were not just big hematomas. These were small hematomas. These were any hematomas. So not necessarily ones which you're worried about it bursting out. The little lump under the skin was enough to do this. But the envelope reduced the infection rate by 82%. You could almost say that infections are a problem of hematomas, since the vast majority of the infections occurred in patients who had hematomas. Now, why did people develop hematomas? While the overall rate was 2.2% hematomas, there were multiple risk factors for this. And we're going to go into this a little bit more. But the thing I want to focus in on particularly was the impact of the use of anticoagulation. So unlike most other surgeons, electrophysiologists are much less careful about the use, doing operations that are not on anticoagulation, because we are the major purveyor of these anticoagulants, mostly for atrial fibrillation care and preventing strokes. You notice that if you had no antiplatelets and no anticoagulant use, your hematoma rate was only 0.82%. Just the adding of an antiplatelet, which was either aspirin or Plavix or anything like that, it went up to 1.5%. So just antiplatelets increased your rate. But at whether it was warfarin, whether it was a DOAC, the antiplatelets essentially double the hematoma risk of whatever your state is. So on warfarin, the hematoma risk was 2.89. On DOACs, it was 1.73. But you see how this worked. Now, the crazy thing here is 85% of our patients were on either antiplatelets, anticoagulants, or both. So basically everybody, not everybody, 85% of people were on these things. And I'm telling you that hematomas are the driver of infections. So what about anticoagulation management? And if you're familiar with this field at all, there were a couple of really nice trials done out of Canada where they looked at different ways of managing anticoagulation. There's the uninterrupted anticoagulation, there's interrupted with bridging, and there's a few patients that we didn't know. So if you had only, you didn't interrupt the antiplatelets, the risk of hematoma was 3.45%. If you uninterrupted the anticoagulations, is up to 6.45%. If you interrupted it, you just interrupted the antiplatelets and the anticoagulants, you drop that rate by half. If you thought you're going to be smart and you were going to, because they have a mechanical mitral valve or something else like that, you were going to interrupt them, but you're going to bridge them to make it really careful. That is a really bad strategy to do so. Because now your risk goes up to 8.33% developing the hematoma. And so the point being is that having uninterrupted, or if you can interrupt, because your risk over a few days is really quite small of having a blood clot and a stroke. There are people that you don't want to interrupt, but on the other hand, most people can be. And for most other surgeries, they are anyway, even if you say that they can't be. So we should really strongly encourage the interruption of anticoagulants. Now, interrupting and bridging is worse than not interrupting. And previous studies have compared these groups, the uninterrupted versus bridging. But the real key is the ability to do both. So the key takeaways are CIED infections. Pocket infections are reduced by antibiotic envelope. Mortality reduced by antibiotic envelope. I didn't show you that data, both true. Pocket infections often occur late. All hematomas increase infections. The antibiotic envelope reduces infection with hematomas. The hematoma increased with anticoagulation and with antiplatelets, and even worse with both. And the real takeaway is that we really should be more careful about how we manage anticoagulation and antiplatelets around us. And I'm not saying that you need to stop them all the time, but I think you should think about it. So that's one update, and we can talk about that further. And there are a lot of other lessons from RAPID. I'm also going to do an update on lead preparation. This is the landing page for lead connection. Again, with the so if you want to join in, there's a very special trend that's going on in electrophysiology at this point in time, where we're trying to engage the natural conduction system by placing leads either in the His bundle or more commonly at this point in time into the left bundle, and getting natural rapid activation of the heart. And the most popular way to do that is using this Medtronic 3830 lead. This lead is a cable-driven lead and very thin, and is delivered by a catheter rather than by stylets. Those are all nuances, but this is a revolution in the way leads are being delivered in pacemakers and defibrillator cases. The problem is that because of infection and because of lead failure rates over time, the need to remove these leads has increased. And early on, every lead is easy to take out. But as they're in a decade or longer, they become much more difficult. And these are some new techniques that we have on lead preparation. and some new insights that we've recently published. And when we do this, we take sheaths and we slide them over the leads, but there's no lumen here to put what's called a locking stylet in. So we have to pull on the end of these leads. And we can reduce the size of the lead and the sheaths that we can use by stripping off some of the plastic here and making for a better connection. And we've, for the first time, and I've spot many parts of cardiology does bench testing, but I have to say that lead extraction hasn't been this way. So we actually measured how strong these leads were and found out that there's a special way that the inner coil, if you prep them right, the inner coil can break, and then later the outer coil can break, but you can prepare these leads well. This is a special knot that we...
The constrictor knot. Grasp the suture, place it in the palm of the right hand.
And essentially, we take the lead,
create an overhand loop.
We're able to tie this knot in a particular way
with the right forefinger and
a much
thumb.
better way of
the
preparing
reversed
this.
way, grasp the loop with the left forefinger and thumb, and then fold over the loops. So you have a circle. Once you have the circle, you pass the lead through the circle down onto the insulation, and you tighten the suture. As you tighten, you ever constrict more tightly the lead and its components.
So the point of that we're going to make with this is that we haven't done a lot of science about understanding how best to do it. It's very individual. It's and everybody seems to be convinced that they have the right way to do it. So providing data that allows people to understand that there is a better way of managing this. We use this tie on all leads now, and it makes a huge difference with particular sutures as well. Now, I know that's highly technical and probably not as appropriate for this general group, but I have to say that the perception of lead extraction is that it's this very dangerous, very almost cowboyish type of procedure. I've been doing it now since 1988, and when we were doing this originally, they were just starting to do ablations at the same time. Matter of fact, the kind of ablations they did at the time where we were doing DC ablations. And there's probably nobody in this room that remembers the DC ablation, where we hook up an external defibrillator to a catheter inside the heart and give 360 joules down the catheter. And it would do AV junctional ablations. You remember that? Okay. And it would destroy the catheter, which was platinum. You'd see pieces of platinum inside the heart. And there was a audible bang. And if you had the lights off, the body would glow. Then you took it out. And, you know, there was a question back in 1988 or so when we were doing this, whether I was being more barbaric by doing extractions or they were being more barbaric by doing an ablation. So things have, and people have worried because we're pulling these leads out and we're taking them out of the veins, and there's a potential for complications. But the overall complication rate for major complication is about 2%. At worst, it should be 3%. The overall mortality rate, if using proper rate, should be less than 0.5%, probably closer to 1/4%, which doesn't come up to the perception, the public perception, that if you have a lead extraction, you're going to kill my patient. And the reason I'm bringing this up now, because I'm going to talk about infection awareness and why and how poorly we have treated our patients. So, oh, why is it going that way? Okay, So in March, I had the honor of leading a national summit on CIED, Cardiovascular Implantable Electronic Device Infection Summit. And we brought together 40 stakeholders, convened them, and trying to figure out why people weren't being treated appropriately for these diseases. And I'll give you some of that data in just a second. And basically, it came down to three things. One is they perceived that the risk of the treatment, extraction, was too terrible to contemplate. Two, they didn't understand the seriousness of the infection. So let me give you some data points on that. After you treat somebody with, let's say, endocarditis and a CIED infection, and you treat them properly and there's no more infection, those patients still have 20 to 25% one-year mortality. But if you don't do that, they have a 50 to 60% one-year mortality. So we're not talking about minor things here. We're talking about a very big thing. And then the big thing is people just didn't know. They had no awareness. So we tried to bring people from various walks of life to work on this. And it was a very diverse group. ACC, Hypertrophic Cardiomyopathy Association was a patient group, Mended Hearts, a patient group, Association of Black Cardiologists, Infectious Disease Society of America, National Black Nurses Association, the National Quality Forum, the Joint Commission came here, the Black nurses, Hispanic nurses, the Heart Rhythm Society came in, and the Arrhythmia Alliance. The Arrhythmia Alliance is another patient organization. And quite frankly, leveraging our relationships with patients is probably going to be one of the more effective things that we're going to do. So we started this 2-year initiative. You can go to the American Heart Association website and go on. There are now a couple of webinars, another one coming up shortly, a podcast that we've done. We have a conference report, an executive's summary about why this is so poorly treated. We even have it's a hashtag, treat to beat CIED infections, way too long. Not the best hashtag. And so this is a disaster. And I'm going to show you some infection data, how badly penetrated we are with this, and explain to you how important it is that we change the perception about this. And understand that if you're a heart failure doctor, a large percentage of your patients have implantable devices. If you're a coronary doctor, a large percentage of your patients have these devices as well. If your patient has AFib, a large percentage of those patients have this therapy. So this is going to show you a little bit of how bad this is. This is JAMA. This is the teaching site for JAMA, okay? Not a fly-by-night organization, right? So blue pigmentation of the skin, sclera, and teeth. And quite frankly, I learned something from this. I learned several things. And here you can go to the website and look at it for yourself. This guy, look at this guy. He's got black arms and blue sclera and blue teeth originally. So this was a 69-year-old man presented with 1-month history of progressive skin color discolorization. His medical history included chronic kidney disease, chronic hepatitis C infection, cirrhosis, ischemic cardiomyopathy, an ICD, and atrial fibrillation with prophylactic apixaban. So he's getting his apixaban, and he's got his ICD, both for primary prevention purposes, preventing sudden death and preventing stroke. He had recurrent Staphylococcus bacteremia due to infection of the ICD lead. So they made the diagnosis and had been treated for the past 6 months with minocycline. Where you get treating this person with minocycline, which is not a particularly solo antibiotic for this, 100 milligrams twice a day. So the whole point of this case report is to make the diagnosis of minocycline toxicity. This is what I learned. I learned about minocycline toxicity. I thought that was really good. What did they do? So should you discontinue the apixaban, the minocycline, the iron studies? So obviously discontinue the minocycline for their point. So their diagnosis of minocycline-induced hyperpigmentation, what to do next? And they go discontinue it, all this stuff. It says, given this patient's ongoing minocycline use, discontinuing the minocycline is the best answer. And then the patient outcome is minocycline was discontinued and daptomycin was started in its place. The patient declined treatment for pigmentation changed because they were not bothersome to it. So that's wonderful. But this patient who's going to die from his endocarditis and his poorly treated CIED infection, he shouldn't be on any antibiotics. Well, after a month, he shouldn't be on any antibiotics. He should have his extraction and be treated, have it cured, and have it fixed. And so this is a international teaching forum that completely missed the big teaching point on the case. Now, there's more than one teaching point. I must admit that the minocycline is a very interesting case going on here. But this is not the way to do it. What's wrong with this picture? CIED infections, pocket erosions, positive blood cultures, endocarditis require CIED removal, treatment with minocycline, daptomycin. The risk of extraction is less than 0.5% mortality, less than 2% complications. Those, compared to what this patient's enduring over a long period of time, are appropriate. The risk of staph bacteremia is 25% one-year mortality versus 50% mortality without that. I mean, they're not the same order of magnitude of problems that we're talking about. So how bad is this problem? So this is some data that was presented last year at ACC by Sean Pokorny and is in the process of being published. And they looked at the national inpatient sample, the 100% national inpatient sample, and they looked at over 1 million CIED patients from there with 4.6 years of follow-up and 1.1% infections. And what you're seeing here is the cumulative incidence of transvenous lead extraction. Now, these were patients that, no question about it, had endocarditis and a CIED. They waited a year because they said they excluded all people that had their infections during the first year. Why? Because if they had the procedure, it wouldn't be called an extraction. It would only be lead removal. So they waited. The patients were a year old. The devices were a year old. And then they required that they had all the codes for both the endocarditis and the CIED infection. So these patients excluded a lot of patients, but these patients definitely had both endocarditis and CIED infections. And at the end of an admission, because all these patients were admitted to the hospital, this is not just somebody out in OPD. These patients admitted to the hospital with these diagnoses, only 18% of them got an extraction within 30 days. Only 18%. 13% had it done within 6 days. Now, what happened to those patients? So if they had no extraction within 30 days, the cumulative incidence of mortality was about 30%. If they had it done within the 30 days, it was down to about 12%. And then down here at the people had it done in the first week. So not only did most of them not get treated appropriately, and then many of them went on to die. How quickly they get treated is appropriate. Now, I know some other data that's going to be coming out that looks at the National Readmission Database, and they're their incidence of getting extraction in another way was 11%. But the answer is that we really don't have, we don't really have the awareness of how important this is and how this is a life-threatening problem. The last part of the talk, I'm going to talk about new tools. There's a new tool that new company is coming out. This is an Israeli company that it's going to bring us out new mechanical tools. This is the XCardia device. And this device is motorized, which we haven't had before. It's been hand-driven before this. And in addition, and it rotates back and forth and seems to be of value. And in addition, it has the ability to flex the sheath. Be able to change the direction of the sheath actively. You can see it bending there. And it seems to be working pretty well. And finally, you see it, when we bend it, the lead just came right out. So we're going to see more of that. This is another patient, another work. This is a patient who has bilateral subclavian occlusions and SVC occlusions. You see the multiple collaterals everywhere. If you ever wanted to see occluded subclavian systems, this is it. This patient's, all of their venous return is coming through their azygos system and intercostals to below the diaphragm. And we needed, this patient had broken leads and needed a new system to be put in. So we have a new, another new tool. This is the Tight Rail Guardian that will be coming out. Again, another motorized tool. And we can see that it too is being effective. Hopefully it'll be gentler. We'll see how this works out. These are all very early results. This the Tight Rail. This one is not that we don't flex, but has it's less cumbersome to use. And you'll see that we get the Tight Rail Guardian down here. And it really went right through those occlusions that we had before. The last part I want to talk about is community. If we're going to make a difference in infection awareness, in extraction techniques, doing this well, we need to come together. We relaunched our Lead Connection community with monthly podcasts and lead management tips, case dialogues, education opportunities, publication resources. And again, we have our QR code here. Please become engaged. So what should we expect to hope for in 2023? I think we're going to get better techniques. I think we're going to understand how to get more consistent preparation of our leads. Lead extraction techniques specific for conduction system pacing leads. New mechanical tools, I showed you some of them. New femoral tools are going to come out either this year or early the next year. I think there are going to be some additional antibiotic envelopes. And we're continuing with our infectious awareness campaign. I'm really excited about engagement of patients. You think about it, how engaged patients have become, let's say, patient self-breast exam or self-skin exams, and how that's created revolutions in patient awareness, bringing it to the doctor's attention, but also understanding of sort of patient self-advocacy. I think the responsibility for device therapy is combined. I think it's jointly us and the patient. And what we do at the Cleveland Clinic is we give them a 2-page form. On one side, it says, this is what you can expect from us. We're going to contact you. We're going to, when we find a problem, we're going to contact you. If there's recall, we're going to be monitoring you. We're going to see you every so often. On the other side, it's what we expect from you. Coming back and everything else like that. Having that kind of joint decision-making and engagement with the patient. So, they should be checking their pockets. There's change in the pocket, they should be bringing it to your attention. You should be opening the patient's shirt and looking at their chest wall when they come in as well. If we do that, we can change this because people are dying from this very frequent and important disease. So glad to answer any questions, but that's what I intended to share with you today. Thank you. Yes. Oh, there's a microphone.
Oh, right. Okay. Bruce, thanks for coming. It's been great to have you here. We do a lot of generator changes. We all do. And I think managing the anticoagulation at the time of generator change can sometimes be challenging. And I can kind of dictate if they come up, if they're DOAC, or what to do if they're still on warfarin. But I think the antiplatelet agents, usually I'm just afraid to touch because I don't want something bad to happen because I stopped their Plavix or something like that. So how do you manage that, say for just like the normal generator change?
So first of all, I make the decision about the anticoagulants. But then if it's in the last, so it's not just generator changes, first of all. It's generator changes and it's upgrades and mode changes. So the timing of your surgery can be determined, can be sometimes determined about how you can do it as a low risk procedure. So putting off your procedure for a period of time is a reasonable thing to do. Waiting when you're doing it for prophylactic reasons, waiting until their next battery change is a very reasonable thing. You're setting the clock back a little bit and do that. The same thing with if they just had a coronary intervention and they had a stent put in and they need to be on antiplatelets for, 6 months, a year. Often you can avoid that, or if you talk to your coronary, talking to the other people involved in their care is an important part of that. Sometimes you won't be able to stop these things, but you should at least be thinking about it. So the most classical situation that happens with this is somebody has a mechanical mitral valve. We all know mechanical mitral valves have a high rate of clotting, but believe it or not, mechanical mitral valve patients on Coumadin, of course, none of them are on DOACs, right? They're all on Coumadin at this point in time, have their Coumadin stopped all the time for every other kind of surgery. Every other kind of surgery. Now, what I would propose is that you consider letting it at least drift down and then just restart it. And for those people, I'm with a mechanical mitral valve. So let's say it's not 3.5, it's down to 1.5. How long are they at 1.5? A day or two. It's not worth the risk of putting them on Lovenox. And quite frankly, if I was going to put them on anything, I'd probably add apixaban rather than putting them on Lovenox, because we're clear that any heparin product is a really poor thing to do. So you won't prevent all the hematomas, but you can manage this by, and this happens in the hospital. I'll do a procedure. They'll be off their Coumadin, and they go home, and they have risk factors. They had FASCA5, they're an AFib, and such like that. Restarting the Coumadin or restarting with apixaban instead of Lovenox or something else like that is a far better way of going about it. I have a rule that nobody gets started on heparin after an EP procedure unless the electrophysiologist is directly involved, and I almost never will do it after one of the device procedures. But sometimes it still gets done because a fellow, a nurse, or whatever else like that, the gremlins of it in the hospital. It happens. So I think awareness about this. Remember, if you developed a hematoma, not an infection, but if you have a hematoma, and what is the next thing you do? You stop the anticoagulation. How long do you stop the anticoagulation? For much longer than you would have stopped the anticoagulation in the first place. And so the point is, having a short period of time, your risk during those few days. The one thing I agree with you. The one thing I get a little nervous about is the early stents and such like that. But the coronary intervention people are becoming less insistent that it has to be how long it has to be. It's going to be brought in to 6 months. Many patients. Some patients it has to be a year. Some people you can't stop. So I think you can manage this, and if we can reduce the high risk patients and manage it a little bit better, I think we will not only reduce the hematomas, and not just the big hematomas, the little ones too, but we will also reduce infection and will improve survival.
Bruce, I have a question for you. So you've practiced at Cleveland Clinic for your entire career, basically. And we are also at a tertiary medical center. So what are your thoughts on lead extractions at some of these smaller community hospitals that are doing them in terms of outcomes? Do you think there should be some sort of volume or some sort of training in terms of being able to do those? Because when they go wrong, they can go really wrong. So I wanted to get your thoughts on, in terms of training, technique, how you kind of
So there are standards for what should be done, and they've been compromises in some ways. But my personal feeling is that it's not necessarily whether you're tertiary referral or not. It depends on what kind of systems you have in place. So if you have developed a team, which includes a surgeon and the imaging and the anesthesia and infectious disease and all the people that are involved, and they could be individuals, they don't have to be academic, they don't have to be any of those things. And you have protocols and what we put in our last document in 2017 was that you measure your outcomes. So you know what your outcomes are. And you quote your data to your patients. Then I think it's okay. But I think it's a very hard thing for a smaller hospital to do. It's a very high bar to work through. So I think functionally, lead extraction should be done by the most experienced person in the community. And it should be concentrated. When we've said such things in the past, it's been said that we're self-promoting and elitist. I don't know that that's really true. I mean, it sounds that way, but what's really true about that is that it's for the patient. And this is not the only procedure or technology for which volume equals quality. And because it's hard to assemble a team, it's hard to do those things unless you have a certain volume. Wendy?
My question is, looking at that trajectory of timeline to intervention and associated mortality, is there a point at your institution or for yourself where, let's say there is someone in the community who's been dwindling septic, trying to treat through with antibiotics? At what point, and then now they're in septic shock. Is that a person that you would accept on transfer to try to attempt an extraction? That question comes up for us a lot, and now with Vizient data being scrutinized more closely.
This is a tertiary care question, and we accept virtually everybody, and we do our best to provide that type of care. But that doesn't, so the problem with that, and we talked a little bit about this last night, is that the patient, I mean, the cow's out of the barn long before we get to see the patient. And that's what I'm saying. Delayed detection means death. I mean, a lot of these patients die even before they get to us and such. I think we have to recognize that one, there's going to, the sicker the patient is, our outcomes are going to be impacted by that. But I also think our statistics should reflect what's a salvage situation versus a not a salvage situation. And this is far from the only situation. It applies to heart failure patients. It applies to coronary patients. It applies to VT patients. I mean, in EP, VT is probably one of the bigger parts of this. So I think we have to find good ways of creating the statistics are okay. People die from extraction. No, they die from their comorbidities. The earlier you intervene, the better chance you can get them past their comorbidities. But the surgical intervention shouldn't be avoided just because they're a high-risk patient. But we need to have a way of identifying. So we have a very rigorous M&M system in our EP group. We have a person dedicated to finding and overseeing the reporting of every single potential complication. And it's our best attended conference, and it's really not, it's not to show what went wrong. It's to figure out what we can do better. And it's not about blaming, but the only way to do this, so how could this person have been brought in earlier? How could we streamline? We didn't have control of the time before they got to us, but what about the week and a half it took for us to get them to the lab after they got to us? We had control over that. So there are things that are in our control. We have to make sure our statistics don't reflect the morbidity of the patients as much as what we have control over. And I think setting up systems and definitions and controls like that are essential, particularly in a tertiary care environment. And it is part of our cross to bear, so to speak. We will have sicker patients, and we are held to a higher standard. We will have some patients that will die from things that were beyond our control. And I think we have to be both generous to our colleagues and to ourselves to say and be honest, but do it as a group. It's not for me to judge my complications. It's up to the community to judge them. And it has to be in a, nobody's king of the hill here. I mean, everybody counts here in this environment. We have our nurses as well as our docs at all these M&Ms as well.
Thank you so much, Dr. Wilkoff, for coming all the way from Cleveland Clinic. And I'd like the fellows to escort him to the room so you can have some time with him.
Okay.
It's your question answer time.